Welcome to today's presentation on CT Angiography as a screening tool for high-risk South Asians. We'll be exploring how we can reimagine cardiovascular screening for a uniquely vulnerable population that faces distinct challenges in heart disease detection and prevention. Let's begin by understanding the South Asian paradox, which presents three critical issues. First, South Asians have the highest cardiovascular disease rates with premature atherosclerotic disease, even after adjusting for traditional risk factors. Second, there's high CVD prevalence in metabolically active non-obese individuals, challenging our conventional understanding of risk. Third, current guidelines trigger screening only after substantial disease progression has already occurred, leading to late detection when intervention is less effective. Traditional screening methods consistently fail South Asian populations for three main reasons. Risk calculators like Framingham and pooled cohort equations consistently underestimate and miss the true risk in South Asians. The calcium score alone has significant blind spots, with 40% of patients with obstructive disease having a calcium score of 0 due to non-calcified plaque. This reliance on inadequate tools leads to delayed intervention, postponing life-saving prevention measures. CTA offers a significant advantage in addressing these gaps. CTA reveals calcified plaque, non-calcified plaque, subclinical disease, and provides direct assessment of atherosclerotic burden. The clinical impact is substantial. CTA demonstrates greater sensitivity than stress testing, superior negative predictive value, and can detect disease that CAC scoring misses entirely. This enables truly targeted prevention strategies. Let's address four key concerns about CTA screening. Regarding radiation exposure, modern protocols deliver less than 2 millisieverts, comparable to annual background radiation. Concerning overdiagnosis, most findings are benign and drive appropriate medical therapy rather than unnecessary intervention. From a cost perspective, CTA is cost-effective in high-risk populations and reduces myocardial infarction and CVD mortality. Finally, emerging evidence increasingly supports population-specific screening approaches in clinical guidelines. When we examine radiation risk versus benefit, the numbers are compelling. Modern CTA with iterative reconstruction delivers less than 2 millisieverts of radiation dose. Meanwhile, 40% of South Asians with obstructive disease are missed by calcium scoring alone. One-time screening provides strong risk stratification, and the benefit far outweighs the minimal radiation exposure. The cost-effectiveness of CTA screening follows a clear pathway. First, early detection allows CTA to identify subclinical disease before symptoms appear. Second, this enables targeted therapy with evidence-based statin and lifestyle interventions. Third, these interventions lead to reduced events, including fewer myocardial infarctions, heart failure cases, and cardiovascular deaths. Finally, these benefits translate to lower costs, offset through reduced acute care utilization. Who should be screened? We recommend screening for South Asians aged 35 to 70 who meet one or more of the following criteria: family history of premature cardiovascular disease in first-degree relatives, insulin resistance with metabolic syndrome indicators, elevated lipoprotein (a) levels, or the presence of multiple traditional risk factors. Our best practice framework includes 5 essential components. First, shared decision-making to discuss risks, benefits, and alternatives with patients. Second, selective screening targeting high-risk South Asian subgroups. Third, standardized protocols using low-dose evidence-based CTA with expert interpretation. Fourth, integrated care to guide therapy intensity and risk factor modification. Fifth, data collection contributing to registries to continually refine risk models. The path forward requires systemic change. Historic population studies have underrepresented South Asians, but newer consensus documents are calling for race and ethnicity-specific screening approaches. Pilot programs and demonstration projects will inform payer policy, and advocacy can drive coverage changes. We have precedent for this in mammography and lung cancer screening programs. The fundamental message is clear. One size fits all doesn't fit South Asians. We need population-specific screening strategies that address their unique cardiovascular risk profile. In conclusion, the case for CTA screening in high-risk South Asians is compelling. South Asians face uniquely elevated risk that traditional paradigms inadequately address. CTA provides direct visualization, enabling early anatomical assessment before symptoms arise. While concerns about radiation cost and overdiagnosis exist, these risks are manageable and outweighed by the life-saving potential. It is time for the medical community to re-examine the one-size-fits-all approach and consider CTA screening as a valuable tool in combating coronary disease in high-risk South Asians. Thank you. For more information, go to myflowmap.com to learn more.